I'm Millie Sook. I'm the Health Policy Director of the AANEM, and I want to start by thanking all of you for joining us in this important and very timely discussion of the reopening of EDX labs during the COVID-19 pandemic. A guidance document was recently created by members of AANEM's Quality and Patient Safety Committee, which hopefully you've all had a chance to read. If you haven't, it is up on our website, and I believe it is published in Muscle and Nerve as of today. I'll hand the presentation over to the chair of the committee, Dr. Pushpa Narayanaswamy, in just a moment to provide an overview of the document. But first, I want to publicly thank all of the members of the Quality Committee, and especially the authors of this important document, for the countless hours they devoted to this project. As evidenced by the sheer number of registrants for our first live webinar, which is over 260, this is a very important topic. During the presentation, we'll be asking live polling questions and sharing the results in real time, so please be prepared for those. At the end of the presentation, I will read some of the most popular questions submitted in the registration forms, and Pushpa will be joined with two of the other authors, Dr. Urvi Desai and Jayashari Srinivasan. They will assist in responding to your questions. You may also submit additional questions in the chat box, which we will try and get to as time permits, as we're hoping to keep the webinar to just an hour so that we don't take up your entire evening. And with that, I will hand it over to Dr. Narayanaswamy.
Good evening, everyone, and thank you for joining this webinar. I'm glad you're here because this document was developed primarily in response to member questions. As we started getting questions, and as we ourselves were struggling in our practices, figuring out this moving target of first closing our practices and then reopening and how exactly to do this, we realized that this was an opportunity to put together something that gave us some practical guidance. Parts of this come from our own practices, parts of this come from reviewing other institutional guidance, and parts of this, a large part of it comes from the CDC as well. There isn't a one-size-fits-all approach to this. Each of us have different practices. Each of us are in a different setting, and local resources vary. The local infection rates of COVID-19 vary, and these things keep changing. Local guidelines, state guidelines vary. Therefore, we kept that in mind, and our document gives very broad recommendations or guidelines. We also were very cognizant of the fact that this is really not something that's a mandate. So you will see that in the disclaimer, you'll see that in our conclusions, and you'll see that in the wording that we use. Often we use the word consider or may be considered. There's only one recommendation where we said must, and that's for trainees to have personal protective equipment. So again, sort of to put it in the context of where you're practicing. So there's no right way to do this, and this certainly isn't a standard of any kind. With that, let's take the first slide. So, oops. Okay. Sorry. Let me try this. Yeah. So those are my disclosures. And this is really the actual the heading of the document. And I'd like to take this opportunity to thank Dr. Desai, Dr. Kasajian, Dr. Del Toro, Dr. Glebkas Martins, and Dr. Srinivasan, and Dr. Benesi, who literally got this together within a week. And I'd also like to thank Sherlyn Atkins, as well as the AANEM board members, for having had a weekend meeting to go through this literally line by line and get it approved. So we talked about various topics here, and I'll go through them one by one. First of all, in terms of patient scheduling, what are we looking at? The main issue here is to allow for social distancing and avoid overcrowding of the areas of the lab and this waiting area, to be able to have enough time to clean the laboratories and the equipment, and also to perhaps also recognize that we may have a smaller than usual workforce. And therefore, we may have to lengthen the intervals between appointments. We may have to stagger them and perhaps reduce the number of appointments when we first start reopening routine services. And if we reduce the number of appointments, it is very likely that we may have to have extended hours, evening hours, Saturday hours. And we recently published another practice guidance, again in response to member questions about how do we really stratify EMGs. And so I think it's reasonable when we are still sort of maybe still escalating services and not at full capacity to look at requests that as they come ourselves and perhaps try and prioritize which patient needs to be seen sooner than later so that patients receive appropriate care. It is important to instruct patients when we schedule them to call ahead before the appointment if they develop COVID-19 symptoms. The paper provides a checklist. I'm sure most of your institutions have checklists. And again, although most transmission is aerosol transmission, I think also to consider contactless collection of co-payments, whether it be by telephone, whether it be using other kinds of equipment, may be something we may want to think about. So let's take the first poll question here. So at this time, what kind of patients are you seeing for electrodiagnostic evaluation? And I'll read the answers here. A is you're seeing all patients except for confirmed COVID-19 positive, regardless of urgency. B is all patients, including confirmed COVID-19 positive, regardless of urgency. Only the cases that you think are urgent, or you're not doing any at all, you're still closed. And go ahead and answer this, and Millie will put up the responses and read the responses.
I am not getting any responses in. Oh, so if people, it looks like for some reason when these got entered, all of the questions got entered at once. So please just answer that first question. Okay. These were not entered correctly, so oh, it looks like some people are able to answer. You have to answer all of the questions to submit. Okay. Well, our apologies. This is our first time running this. I'm going to leave this open then for probably another 60 seconds or so, since apparently it's going to make you answer all of the questions.
So all of the questions that are in the polls subsequently?
Yeah.
Millie? Okay, so I may not read those questions when we're going through then.
Yeah, I'm going to let people a little bit more time answering. People are asking to put up the questions again. I can't give you the question again if you already answered it. There's no way for me to release it back to you. It looks like we're getting some responses. So for that first question, it looks like a slight majority are seeing all patients except for those that are confirmed COVID positive, regardless of the urgency. About a third are seeing only urgent cases, and then about a quarter of the respondents said that they are still closed.
Okay. So can we go on? Or do you want to wait for a few minutes for other responses, or can we go on?
You can go on.
Okay. All right. So the second issue that we talked about was what happens when patients come in to the facility and how do they register? So the first issue, of course, is to monitor the point of entry. Again, the whole point of this is the same thing, social distancing to keep patients and healthcare personnel safe. And some of the ways that we've looked at are to perhaps have patients wait in the car or the parking lot and call from the parking lot and schedule and say that they've arrived and check in and continue to wait there and either wait for a call from the registration desk that they can come on in for the appointment, or have an escort. In some places, they have an escort to take them in when it's their time for appointment, or just show up after checking in from a distance, just show up at the registration desk at the time of the appointment. It's important to have the 6-foot distancing in the waiting areas for chairs, and also to mark very clearly the 6 foot so that patients are aware where they can wait, and to have separate entrances and exits so that patients are coming in and going out and not crossing each other. Perhaps consider people to escort them in and out. And in terms of accompanying patients, certainly this is something we've implemented. So accompanying patients are really limited. People accompanying patients are really limited to this, really only if they're absolutely necessary. So if the patient is cognitively impaired, and not necessarily if they need physical help, because we can have staff help with that. So really to limit the number of people. Now, this is a big one. It's a real concern. There's lots of data, lots of questions out there, not too much data. And what we did was to get most of the data, sort of look at it from the sense of the procedure being electrodiagnosis. So put that factor in, factor that aspect of it in to come up with some guidance. So of course, we do want all patients to wear face masks and perform a proper hand hygiene, and that's either hand washing or using sanitizers with the approved alcohol content. There was a question about where we got that alcohol content and the kind of alcohol. That's straight from the CDC website. They have to do this, perform the hand hygiene, obviously, before the electrodiagnostic testing. All healthcare personnel with patient contact should wear personal protective equipment. And so how do we define that? So in patients who are not suspected of having COVID-19, the personal protective equipment that we think may be relatively simple to use and also not make the procedure overly cumbersome is clean, non-sterile gloves, a surgical mask, and either goggles that fit properly or face shields. So either the disposable face piece respirators, which are commonly known as N95, but there are several equivalent ones available, are acceptable, but they would probably not be needed for patients who are not suspected of having COVID-19. Even in patients who are not suspected of having COVID-19, if we're talking about high-risk electrodiagnostic studies, and that's where we sort of factored in exactly what we do. Facial studies where we have long, close contact with the face, we're doing single fiber EMG, etc., or laryngeal EMG, then we do think it may be useful to use isolation gowns and use the N95 or an approved equivalent in addition to the gloves. And then one thing I realized during all of this was that it really is not simple to get all of this on and off. And then there are very clear procedures and an order in which these come on and off. And therefore, it's important to know that there is a link, a CDC link in the document that really tells you how to do that. So do I need to read this question, Millie, or can I go ahead or give
you
folks
can read
some
the
time to
question
answer?
and I will read out the results because people answer those questions.
Okay. So this is the second question. What type of mask are you using in standard electrodiagnostic testing in patients who are not suspected of having COVID-19? So surgical masks and goggles or face shields, N95 or equivalent masks. So we're talking about a filtering face piece respirator and goggles or face shields. Other types of masks, for instance, a cloth mask, or none?
It looks like the majority, over 50%, are wearing surgical masks and goggles or face shields. About a quarter are wearing, the healthcare providers wearing an N95 or equivalent mask and goggles or face shields. And then about 10% are wearing a cloth mask and 7% are wearing none.
Okay, thank you, Millie. In terms of screening of both patients and healthcare personnel, so almost all our institutions, and for those of us who are institution-based, there is a daily screening for all healthcare personnel who have direct patient contact. The document that we published and is on the website gives some of the questions for daily screening that you may use in practice. Is pretty standard. You can get that anywhere on the CD's website, etc. And it's probably important also in individual practices to make sure to self-screen and to screen colleagues or however it is that you want to do it, but there has to be a screening method. In terms of patients, we already said they would call if they develop symptoms after being scheduled. We told them, please call. But they need to be screened the day prior to appointment and also when they come in for their appointment. One thing we struggled with a little bit was checking temperatures. It's possible that patients may not be, they may feel just a little sick. They may not be really able to answer if they're feeling very sick, or they may just want their electrodiagnosis so badly they say, no, I don't have a fever. So we could consider alternatively, in addition to the screening, the screening questions. So really symptom screening is a huge part of this. In addition to that, we could consider checking temperatures. I've heard that some of the no-touch thermometers may not be very accurate. So again, this has to be sort of done on an individual basis, what it is that you're most comfortable with. In terms of COVID-19 testing, and I anticipate there'll be some questions, there have already been some questions about this. So a few things in terms of the literature. So there are no guidelines on pre-procedure testing for COVID-19. And there are various reasons for this. Most institutions and even the CDC recommendations are symptom-based screening. The reason for that is this. We all are aware of asymptomatic carriers, but and that's a risk. But in terms of the actual the people who have infection, they are not likely to shed after 10 days. So, and we'll talk about that in terms of isolation. But mostly, if you think about it, even if they screen positive, then you're going to have to, if they on the questions, then you're going to send them off somewhere. If they screen negative, then the concern is that they may be an asymptomatic carrier. But you're going to use PPE in all of them. Just because somebody screens negative, you're not going to not use PPE. But in terms of managing this, again, in communities where the risk is high, it's possible, and when the resources are available. So risk is high, resources are available. We could consider COVID-19 testing, which would mean the nasopharyngeal swab for PCR of all patients 24 to 48 hours prior to the appointment. And we said that this should really strongly be considered for the higher risk studies, for the facial studies, for single fiber EMG of the face, etc. And of course, we have to know what to do with these patients who report symptoms or test positive. For COVID-19 positive patients, people who had an infection, how do we deal with this? So we require evidence that the infective phase has passed. And how is that? So if we do a PCR on patients who have had COVID-19 infection, so the sensitivity of the PCR is not complete. So first of all, if you screen them, they may not have a positive PCR despite having infection. So that's the other reason for considering just a symptom-based screening. If they are positive and they've had the infection, they may continue to be positive for as long as 6 weeks. But that doesn't mean that the virus is capable of replication. Viral replication really drops off to almost zero by 10 days after the infection. And most patients, if they have been asymptomatic for 3 days, then the CDC studies have really not been able to culture the virus. So even if their PCR is positive, they're not infective. So basically, if you have a patient who had COVID and they have had it over 10 days ago and they've been symptom-free without taking antipyretics for 72 hours, they can come out of isolation. In immunocompromised patients, you do want 2 tests 24 to 48 hours apart that are negative. How do we manage electrodiagnostic studies in the outpatient setting? we do want to limit the number of healthcare personnel in the laboratory to the bare minimum, and also plan the study efficiently. I mean, do we really need edge reflexes on everybody who has suspected S1 radiculopathy, or can we just do the routine conduction studies and do EMG? Do we need ulnar, trapezius, and facial repetitive nerve stimulation for everyone with myasthenia gravis question? So those are the kind of things to just plan it efficiently. And then this is something that we came up with. So I've been doing studies during this time, and one thing I was concerned about was that I would contaminate the supplies on our cart in the laboratory if I needed another needle, or as I was setting up patients for their study. So we came up with this idea of having separate carts in the room. We don't have a box or anything like a kit, but just a chuck. And on the top shelf of the cart, we just have the bare minimum that we require for a test. And then on the second shelf, we have some extra, maybe an extra needle, maybe some extra disposable electrodes, because we use disposable electrodes. And as you know, some of them lose their adhesive when we are doing the studies. So that's a secondary kit. So we still don't contaminate the main supply, and the main supply is now kept outside of the laboratory. Disposable tape measures. Someone had a question about where they're available. They're available on Amazon. I just looked it up. It's just these paper measures. And they cost $7 for 100 tapes. And one of my colleagues actually just said about how you can actually use an image, like a JPEG picture of a tape, and then just cut it and make copies. Disposable heating packs, alternative methods such as heating lamps, of course, you have to clean them. And then one of my colleagues in my division said, well, maybe we should cover the patient completely to really minimize direct contact. And so, again, sort of very common sense items to consider. So are you using disposable electrodes? The questions, that's the next poll question.
Yes, and we do have this up and running now. So we launched questions individually. So we'll give everybody about 10, 15 seconds to answer this. So it looks like, here I can end this polling here. Looks like about 2/3 are using disposable electrodes.
Great, okay. Yeah, thanks for fixing that, Millie. So how about inpatient studies? So if the patient is not suspected of having COVID-19, then we follow the same recommendations for PPE as we talked about in the outpatient setting. Considering also the risk of the procedure itself. If they are suspected to have COVID-19 or confirmed to have COVID-19, I think the first order of business is to really determine if that electrodiagnostic study is absolutely essential. And we all know, I mean, we get called for various studies that may not necessarily change management. And so I think it's important, the way we've been doing it is just reaching out to our colleagues and sort of talking it through and seeing what exactly the question is that they want us to answer. I mean, I had a patient who I was consulted for because they were worried about a radial neuropathy or I don't remember, maybe anterior introsus, because of a compartment syndrome from a line in the forearm. In a patient who actually had a hemorrhagic complication of COVID-19. And I said, well, why don't you just get an imaging study? And sure enough, she had a hematoma. So that kind of thing. And if the electrodiagnostic testing is deemed necessary, then of course, we do want the full personal protective equipment, including the filtering face piece respirators, isolation gowns, etc. And a couple of things we have been trying to do is to perform the studies at the bedside so that the patient is not transported, the lab is not contaminated, it's only the equipment that we have to clean. And again, to minimize the personnel to the bare minimum required to perform the study. And one of our colleagues, Dr. Srinivasan here, came up with a point of maybe performing the study as the last study of the day so that, we have enough time then to clean the equipment and we don't have to hurry to use it for another patient. There have been some questions about cleaning and disinfection. So cleaning and disinfection are two separate steps. Cleaning is soap and water, and disinfection is, of course, antimicrocidal wipes or whatever it is. For electrodiagnostic equipment, the first thing is we just need to follow manufacturer's guidance in the booklet that they have with the equipment. Of course, don't use bleach because it can ruin the equipment. One of the other things to consider is to really put one of these plastic keyboard covers on the keyboard of the computer. You can even get these plastic covers that can go on the machine, which is easy to clean, can be wiped after each use. And minimizing and removing non-essential objects in the lab. We took off our curtains, we took off upholstered chairs because they can't be wiped down, so we have chairs that are just covered in plastic, not cloth, etc. And in terms of the lab, at the end of the day, if we don't, I mean, this is just an extra step of cleaning, just being extra careful. We've always done cleaning procedures between patients, but I think this is a little bit more intense. And we may just need to do it if we don't have custodial staff between each procedure. And this is basically what I said earlier. And I think Dr. Desai mentioned they are using clean and sanitize signs on the door. I think that's very important because it gives patients confidence as well when that's done. So this is the next poll question. What cleaning, disinfecting protocols are you using in the lab? And you can select all that apply for this. Plastic covers for EMG machines, using soap and water. I'm sorry, this thing pops up and I can't read it. Give me 1 second. To clean hard surfaces and then disinfecting the entire room after each patient. Removal of all cloth and unnecessary furniture and objects in the testing room. Placement of a clean and sanitized or similar signage after each patient.
It looks like this question is only letting people select one, so
Okay.
our apologies, but we'll close this poll. It looks like the most popular answer was using soap and water to clean hard surfaces and then disinfecting the entire room after each patient.
Yeah, and I think that's really a very reasonable, I mean, that's what the CDC recommends. So that's a very reasonable way, I mean, to do it. So we're almost done. I want to leave enough time for questions. Whoops, did I? Okay, so the next one is for those of us who are involved in training fellows and residents, this is a very difficult time. We do have to balance training requirements, the number of EMGs required, for instance, with their safety and minimizing exposure risk. And this was, like I said, the only must recommendation. We must provide our trainees with all personal protective equipment that we use, and we have to train them on how to use it. In terms of other things that we do as part of the procedure, when we do sign-outs, for instance, when reviewing their reports with them, I think it's important to follow social distancing. The way we've been doing it now is that they sit in their office on the phone, I sit in my office on the phone, and we talk about the report. And then, of course, we've also been doing a few afternoons, one of my colleagues does this, to utilize some supplemental forms, for instance, EMG case discussions to supplement their learning of this sort of active thinking process of doing electrodiagnostic studies. So I think this is the last poll question. How are you handling electrodiagnostic training of residents and fellows? Select all, and I don't know if it'll let you do that, but not having them perform any, okay, you fixed it. Okay, thanks, Millie. Not having residents or fellows perform any electrodiagnostic testing, or just reducing the number of all electrodiagnostic testing, or not having them perform any high-risk electrodiagnostic testing, either because it's a facial study or because the patient is COVID positive, or just reducing the number of high-risk testing.
All right. We'll give people just a couple more seconds because we're getting a lot of responses in still.
Good.
All right. It looks like the most popular was the top one, not having residents perform any EDX testing on any patients.
Yeah, yeah. I think it's a real issue. I mean, we do have to consider their training. It's a hard issue. Okay. And we're almost at the end of this. So patient care. So how do we reassure our patients when they come in? I'm sure patients are worried if they have to come in. So one of the things, we always obtain verbal consent for electrodiagnostic testing, but I think it may be reasonable to discuss the benefits of electrodiagnostic testing versus the potential risks of contracting COVID-19 when obtaining informed consent, and sort of explaining to them how that risk is minimized. It's not zero, but it's low because of all of the care that we're taking in addition to just the PPE, and they are wearing a mask, also all of the cleaning, etc. And to reassure patients about that, and to say, even perhaps Dr. Venesi came up with, one of the co-authors came up with this and said, you know, they've been considering posting the protocols, cleaning protocols in the room, so that when patients come in and they see these protocols, they're a little reassured about it. And these are some of the AANEM resources that are available on the website. And you can always post questions on AANEM Connect. One of us from the committee, and oftentimes Millie or Carrie, will respond to the questions. So I'm going to take a couple of questions these are just supplemental slides that I put in here after we got some of the questions sent in before this meeting. So one of the questions was, can we use a HEPA filter in our rooms? So what are HEPA filters? So you can get them on Amazon. And let's talk a little bit about them. So basically what you have to consider, they basically filter the air by changing, sort of replacing the air. So we know that droplets may stay in the air in a contained space for about 14 minutes. But in the routine electrodiagnostic patient who's not coughing, the risk of actually having a whole bunch of droplets is low. That's different in patients who are sick. Now, the air change per hour is really the amount of air volume added to or removed from a space, for instance, your electrodiagnosis room, divided by the volume of the space. So how many times you circulate that air. So you get these HEPA filters on Amazon, and we looked at some of them because we wondered about them as well. They provide about 250 cubic feet of clean air per minute. Assuming our room is about 1,000 cubic feet of air, it would take 4 minutes to change the air in the room completely, or 15 air changes per hour. Now, unfortunately, it isn't that simple, because there may be a difference between systems that recirculate the air and actually bring in outside air, systems where the air is stagnant versus circulating air. So the bottom line is, this is a question for your HVAC folks and your engineering folks. This is from the CDC, and the link is down, and I can send it to any of you if you want. So if you look at it, this is the number of air change per hour, and this is the time in minutes required for removal with 99% efficiency. So basically 99% of the air is turned around. So if you do 15 air changes an hour, you need 18 minutes. So if you say, I'm going to redo that room and I have 18 minutes, so that may be the way to go. But again, this is very simplistic. This is not something that we are even talking about here. This was just information stuff that I put on here. This is a question for the HVAC and engineering folks in your building. So there was a question about cleaning of the N95 and reusing the N95. So the first thing is to know how to use it without contaminating it, removing it and putting it on without contaminating it. And there are guidelines on the CDC. The second thing is we know there's some data. Again, all of this data is really moving so rapidly. It's a rapidly moving target, changes. So that is something that you have to bear in mind. But it can stay on surfaces up to 72 hours. So if you think about it, if you have 5 N95 respirators, the filtering face piece respirators, you use one, and then you take it off carefully and put it in a paper bag and keep it alone, and then you use the next 4 sequentially, and then you come back to use the first one is decontaminated. There are also other methods, as you know, UV light, etc., has been recommended to clean these microwave steam. There are various methods that have been recommended to clean these, and so that is something that can be done as well, depending on your institutions and your resources. I'll stop there, and I think we are open for questions. And I think maybe we can just turn the video on so that we've got the panelists on for questions. Okay.
All right. So this is Millie. I'm going to go ahead and start by just reading some of the more popular questions that came in through that registration form. And we're also monitoring, and I'm seeing some questions coming in on the chat box. So we're going to try to get to as many questions as possible. If we do not get to your question, please, please, please go online and use our resource, AANEM Connect. That will allow all AANEM members to see your questions and respond. And specifically, we're having members of the quality committee monitor that and respond to that as well. So again, if we don't get to your question, please go ahead and post it on there. And with that, I will start with the first question from the registration form. How would you suggest reopening? Should we wait for the state to enter the last phase of reopening? And I think with that first question there, I will pass that off to Urvi.
Thank you, Millie, and thank you, Pushpa, for a wonderful presentation. These are very timely questions, and we are all going through very unsettling times. So I'm so glad that so many people have come together. Regarding the reopening or re-entry question, I think that a lot depends on local institutional guidelines. There's also a lot depends on what is the infection rate in your community, and how the results are coming from the local municipality or such institutions, or your state or other federal guidelines. So I think it really depends on how you can design according to that policy. And the other thing also to remember is that we're not sure how long we can continue to postpone these studies, especially when it does affect the patient management. So I would consider those 2 points carefully regarding the re-entry question.
All right, thank you very much, Urvi. The next question, I think Pushpa kind of addressed this, at least from her perspective in the presentation. So maybe I will pass this question to Jay to see if she has anything to add to this. But what problems have you encountered thus far with reopening or while just performing EDX testing during the pandemic?
So thank you again for inviting me to do this. Thank you, Pushpa, for a great presentation and for a very good paper, I think, which was timely and much needed. I think it answers a lot of questions. From our point of view, we haven't fully opened the lab yet. We're only doing very urgent studies. And we are doing limited studies. We do have a fellow, and we are trying to get the fellow trained. And it's been, I think, a little difficult to make sure we are maintaining, all the guidelines with the fellow while doing the study. So other than that, we are using a lot of the criteria that was in the document to start scheduling patients and to start doing the studies carefully. And so I think using these guidelines, I think we should be okay to do them. One of the things that you brought up was the fact that you wanted us to have 5 N95s. I can just tell you that we don't have that kind of availability. So the PPE, to a large extent, may be dictated by the local situation, I think, and what is available. And this is a guideline that just kind of tells you what the ideal situation is, and we may not all achieve that.
Yeah, I agree. I think that's a really important point. Thanks. It is so much resource dependent, but also I think one of the things is to start, and the way we are doing it is to sort of start phasing, sort of dip our toe in the water and see how it goes and troubleshoot as we go.
Thank you both very much for that input. Another question that we received, which actually I think I'll probably answer it, although Pushpa touched on it as well. What is the legal liability of not following these guidelines? If you read the paper that's up on our website or the version that's in Muscle and Nerve, you'll note at the end that there's a very thorough, long disclaimer that says these guidelines don't constitute a legal duty to comply with them and that they're intended for educational purposes only. So the answer to that question is you should have no legal liability, as we're aware that it depends on what the availability of testing, PPE, it just depends on your geographic region. All right, another question that we've gotten, and I've seen it come up in the chat as well, so I want to be sure to get to this. And I'll direct this one to Urvi. What if a patient refuses to wear a face mask? Can we refuse to perform the test? Have you had this happen?
So I have not had this happen, but this is definitely, in a way, a bit concerning for everyone involved and present. So of course you want to explain the patient why it is so important to wear the mask and how we are reducing the risk of transmission if someone to cough, especially the patient. But I think that there are some discussion that we had amongst the panel, and if the patient are claustrophobic, there is no way they can use the mask, maybe they can wear a face shield. That probably would reduce the risk to some extent. I don't know if we can take the decision to just completely say, no, we are not doing the study, but I guess it would be case-by-case basis.
Also understanding, I think that face shields may also be hard to come by. Again, it's resource dependent. A lot of nuances there to consider.
Thank you both for that. One kind of specific question related to equipment that we received was, how do you recommend cleaning ring electrodes for sensory tests? Jay, do you want to take that?
Yeah, I think one of the things that we have done in our lab is to move away from reusing electrodes. So we've moved to completely using disposable electrodes. And I think that may be something we all need to do in the short term, at least while we are in the midst of this pandemic, to use disposable electrodes. I don't know if Pushpa or we have anything they want to add to that.
So we are also using, we are also using all disposable electrodes. But if it comes to, I think that they can be cleaned with, I guess, 80% ethanol or soap and water. And so clean, wash with soap and water, and then maybe disinfect. The manufacturers may have the guidelines that one can follow as well. But as Jashi says, I think the best thing is to go with the disposable electrodes in this situation.
Yeah, while writing this document, I actually went and looked at the booklet for our machine and the manufacturer's instructions. And so there's a little section there on cleaning the machine and cleaning the electrodes, cleaning and disinfection. So I think at the end of the day, so that we are not at risk for ruining the equipment, the best thing to do is to sort of follow manufacturer's instructions on cleaning and disinfection. Yeah, and we are using disposable as well. So, but I think following the manufacturer's guidelines would be the safest way to do it.
All right, thank you. Another question that we got in the registration forms, and I've also seen it come up in the chat as well, and that is, has anyone considered a plexiglass divider between the patient and the doctor with a cutout for the doctor's arm? Urvi, do you want to take that?
I think it is going to be really cumbersome to use the plexiglass. How big you are going to make it? How are you going to position? What if the patient is not masked behind the plexiglass? How are you going to go put a small hole within that when you are trying to approach different muscles on the limb, but in different areas, or moving your tape, or measuring and moving the electrodes. So in my mind, I think this is going to be very cumbersome to do this study. I know that this type of dividers have been used for intubation, for example, and they may have other uses, but I doubt that in diagnostic studies they could be useful.
Yeah, I'll also add there that, you know, there's been consideration given to using them, say, at the front desk. We are not doing that in our institution, and the main reason is that the contact at the front desk is likely to be brief, less than 10 minutes, with low risk, especially when both the staff and the patients are masked. So that is not being used. And one member commented on AANEM Connect about how cumbersome it can be with all of this PPE already. And I think we really have to balance what is necessary and what is really useful in terms of protection with how cumbersome we are going to make it. It's not like an intubation that is finished and done. We are sitting over there. And so I think given that balance, we did not have any recommendations about it. I haven't seen much. I know that many stores, many commercial establishments are using them, but I do not know very much about this. And if our members have any experience with this use, please send your comments so that the rest of us can share them.
Okay, and this question, I actually might direct this one to Pushpa. Have you considered use of or use ultraviolet light or similar disinfecting techniques in EMG rooms and or with neuromuscular ultrasound?
Right, so ultraviolet light has not really been recommended, at least by the CDC, as a primary disinfection technique, except for the masks and the specific equipment that I'm aware of. So no, the answer is I don't think so.
Urvi, how do you make patients comfortable with the current levels of safety from the virus? Is your institution taking extra steps in that regard?
Yeah, so I think that it is the whole process that we really need to communicate with our patients, that how we are making them kind of, bringing them in a what we call as a COVID safe environment. So that starts from initial call when we are screening the patients. We are asking them any high risk symptoms, any high risk exposure. Travel is probably not the best at the moment as it has become a pandemic. But starting from that, when we are really asking and screening them, they understand that why we are requesting that they answer appropriately. And then based on that, we are deciding whether testing is necessary or not. From that to bringing them, as Pushpa has quite in detail explained about the distancing, predominantly trying to do a contactless check-in process, bringing them in the EMG lab, without trying to expose them to any other possible contamination, using all the hygiene, making sure that we are placing, not only we are cleaning and sanitizing the equipments in the rooms, or placing those notices on the door or even in the exam room, appropriately masking ourselves, masking the patients, using appropriate PPE, and then while taking the consent, I think explaining them that what we have done, why we are at risk, and why that a particular electrodiagnostics testing is necessary for the management, and how we are going to utilize that so that they feel comfortable, they feel that they are going through the study because it is important for the outcome. So putting it all together, I think that it is always very, very important to make sure that our patient feel comfortable coming to the lab, and we providing them a COVID safe environment as much as possible.
Thank you. I think for this next one, I'm actually going to combine two questions. So it's going to be a two-part question. And I think it would be helpful if we could have each of you all three panelists answer this question as to how your institution is handling this. And I'll start with, we'll go with Pushpa and then Jay and then Urvi. So the two questions are, what approach to patient capacity, for example, starting at half capacity, are you taking when it comes to reopening? That's the first part. And then the second part is, what is the average time interval that you're scheduling between patients? I know you kind of touched on this a bit in your presentation, but this has come up several times.
Right, so thanks, Millie. So we are still at the point of doing just urgent testing. So this is still very much in a planning stage in my institution. The plan is to probably cut by about 50% of the full schedule to start with, and then go from there. But we haven't done it yet because June 8th is our proposed thus far. It's been sort of moving forward every week. So June 8th is when our institution will let us open for routine studies. So it remains to be seen. And then in terms of staggering them or intervals, if we're only doing half the volume, we may not have to, because we'll just run 3 labs and perhaps bring them in staggered by 15-minute intervals rather than lengthening anything so that nobody comes in at the same time. But that will also depend on how many people are available to do these tests. So right now, we're also not sure about our workforce. So I cannot really comment on exactly how we are going to do the scheduling, but I will say that the numbers that we've been floating around are 50% of our usual lab capacity.
So I can go next. So similar to you, Pushpa, we haven't started doing routine studies yet. We're going to start with 4. We just randomly picked that number out of the blue. And so we're going to start with 4 studies for the first couple of days, just to kind of make sure that we have plenty of time to sort of debrief if necessary. And then maybe ramp up to 6 to 8 studies, depending on how it goes. So that's the first step. I think, you know, there was a second part of the question. I'm already lost the second part, Millie. But I think that we don't know what's going to happen, and we're using the criteria that was published to schedule these patients and to sort of slowly ramp up and see how it goes.
The second part of the question was just how long your interval is between patients.
So yeah, so we're going to try, so we have multiple rooms, obviously, and so we're going to use a different room for each patient, and I don't know if that kind of answers the question. So start with patient in room A, and patient 2 would be in room B, so we give room A some time after we've cleaned it to sort of dry out, and maybe for the air to get cleaned up. And so that's the plan, I think. And so the interval between, in terms of the same room, the patient going back, maybe a couple of hours or so, or maybe even longer, depending on you know, how much we ramp up. So we're going to start with small numbers of patients and then ramp up and see how it goes. Yeah, 4 to 6 patients in one day we are going to start with. Over to you.
Yes, so I'm going to start with a second question. What is the time interval? So what we have decided, and this is about one physician practice. If we look at that, we have more than one physician, but we are not doing the studies on the same day. So other physician comes on the second day and then the third day and things like that. So what we have done is that scheduling patients at 2-hour intervals. So our first patient is at 8, so 8, 10, 1, and 3. And the reason to do so is that we have enough time to clean and disinfect, and we have there is no overlap of the patients in the clinic regarding the EMG in the EMG lab. So that has reduced the capacity to 50%, and I think that we are going to continue this way at least for some time to see how we all feel comfortable and what is the now North Carolina. I'm in Charlotte, North Carolina. It has the restrictions have been gradually declining, and so we will see if there is increase in the rate of infection, and it will depend on that as well, how my institution deals with the further increasing the number of patients.
Great. Moving on to our next question, Urvi, I'll just stay with you since you just finished up.
Okay.
how are you handling the increased risks, or are you doing anything different with facial and tongue EMGs?
Yeah, so I think that this definitely is a very, very tricky situation for us. One thing we really need to make sure, and Pushpa had described it quite nicely, is that really, if these studies are definitely to be done, definitely important in the sense that they are going to make a difference in how we manage our patients. If you see the fasciculations on examination of the tongue, do we really need to put the needle in the genioglossus muscle? Again, that it is case by cases that we really have to look into that. And then if you decide, yes, these studies are important, you really need to, for example, repetitive nerve stimulation testing. Proximal studies are always important, but is there a way we can do a little distal muscle, and would that make a difference in management? With all that, if you have to do the studies, I think that it is very important that you use appropriate PPE and make sure that in my mind, and again, this is, I'm talking about myself and not as a guideline or the recommendations, is that it may be useful to use the N95 and not just the surgical mask with appropriate face shield, and making sure that we, for example, we do the EMG of the genioglossus muscle, we discard the gauze if we're trying to hold the tongue with that, or the EMG needle immediately in appropriate bin and containers. So this is something that is always a concern, and I think that each practitioner will have to look at it about how important it is, and then appropriate extra precautions when you do those studies.
I think this is also a situation where we may want to consider actually getting testing oropharyngeal swabs. That was one of the points we made in the paper, that this may be a situation where, in addition to symptom-based screening, we may want actually a negative test. Of course, knowing that a negative test is not 100% sensitive, that's one thing we have to bear in mind. So.
Okay. Jay, I'll direct this question to you. Do you have any suggestions on how to perform a contactless neuro exam, such as reflex and strength testing?
If you do, Jay, let me know.
I'm writing a paper on it. No, I'm kidding. So I think I don't think that's possible. If you really want to do a strength test, you need to touch the patient. You need to check the reflexes, and I don't think you could ask someone else, a family member or anybody, to really do it for you. Ideally, I think you have to do it. So no. So the answer is no. I haven't figured that out, but I think with proper PPE, you can examine the patient and you can check their reflexes. And obviously, you don't want to spend too much time too close to the patient, but if they've answered the COVID questionnaire in the beginning of the test and they don't have symptoms and they are wearing a mask and you're wearing your mask and shield, I think you should be fine doing the thorough examination on these patients. That's my take on it. I don't know if Pushpa, you have something to add to that?
Well, the only thing I will add is, I mean, this also comes up with our virtual visits, right, with the video visits. And I know there's a couple of folks who are working on methods of sort of doing the neuro exam, at least some parts of the strength testing, etc., remotely. It's simple if it's a hub and spoke model of telemedicine where you have a trained observer at the other end, right? But what I have actually been doing is some of my follow-up patients, for instance, my myasthenics, they know I make them shut their eyes tight, and and then their wives will pry, or their whatever, wives or husbands will pry their eyes open a little for me. Things like testing for fatigability you can do on video. I've had families do strength testing. And at least you get a sense of what may be asymmetric. I've had patients say, no, this side is a little bit weaker. So I've done that, but reflex testing, vibration testing, strength, that kind of thing, obviously not.
All right, well, thank you all so much for being great sports and answering all of these questions on the fly. I do want to keep us to our 1 hour time limit here, and it looks like we're just past the hour. Once again, I know that there were a lot of questions in the chat box, and there were a lot of other questions that came through on the registration forms that we just didn't have time to get to. And I just want to encourage everybody again to use the AANEM Connect forum and post your questions there. Again, as I said, the quality committee does monitor that, and as well as any other AANEM members can access that as well to help answer your questions and help guide your fellow physicians. And with that, I think we will close this out. As a reminder, we are recording this webinar, and so we will get it posted hopefully next week to our COVID-19 guidance resource page. So you can look for it there, and we will try to get out an email to all of you as well. And thank you again for taking your Thursday evening to spend with us on this webinar.
Thank you all.
Thank you.
Have a great evening.
Thank you very much.